All right, how's everybody doing today? Little computer difficulty getting started. Okay, so now I think I'm actually live. Um, I'm Dr. Craig Morgenthal. Thank you very much for tuning in. I'm going to talk um, about obesity and the options to win the war against weight. And so a little bit of technical difficulties getting started, but I think we got it under control. So here we go. Um, just hold on a sec, actually. Okay. All right. So I have my first prop here. So, and maybe I should give a better introduction to myself first. So, anyway, I'm a general surgeon at Baptist Medical Center, Jacksonville, and I'm the medical director for the Baptist Center for Bariatric and Reflux Surgery. And so we've got a great program at Baptist, and I'm going to talk about obesity and medical treatment and surgical treatment. And first, we're going to talk really about some statistics. How does obesity um, um, what's the pathophysiology, or how does it come about? And so anyway, so here we go. So number one is body mass index, which basically is a number. And to calculate this, you could go to any BMI calculator, for example, at baptistbariatrics.com. And when you plug in your weight in feet and inches and your height in meters squared, you get a number. Um, over 30 is obesity, and over 35 with a medical problem, such as type 2 diabetes, hypertension, obstructive sleep apnea, that's considered morbid obesity. Or if your BMI is over 40. Okay, so BMI I'm going to refer to on and off throughout the talk. So that's kind of an important thing to start with. So we have an epidemic in the United States. About 70% of the United States is obese or overweight, and that number has gone up over the years. About 39% of adults in the United States are obese. That's the latest data that I could find. I think that's from 2017 or 2018. And about 41% of women are obese, about 36.5% of men are obese, and about 20% of children. And so there's, as I said, an epidemic, and the global burden is driven by the impact of obesity on the presence and severity of obesity related medical conditions, meaning that when you have obesity, you have a number of medical problems that are associated. Um, and as far as costs, we're talking about 150 to 200 billion dollars per year in cost, which is expensive. So when we start talking about what is the cause of obesity, there's different factors at play, and we could get down into a lot of detail. But when you boil it down, there's three main factors that we look at: um, genetics, behavior, and environment. Okay, so there is some genetic predisposition. We know that there might be maybe 50% heritability. There might be a single mutation, rarely. There's unclear multiple genes interplaying with each other, but more so it's behavior and environment. And if you have, for example, sedentary lifestyle, if you're eating excess or high calorie food, and then the main determinant is intake versus expenditure of energy. And so ultimately, when we look at the impact of obesity on your body, I have another sheet here to look at, and we look at different parts of your body that are affected, and you could boil it down to cardiometabolic, biomechanical, and psychological processes. Basically, when we look at cardiac, hypertension, and cholesterol and diabetes come together to cause atherosclerosis and clogging of your arteries, which can cause strokes or heart attacks. We talk about liver disease. One of the most common causes of liver disease now is non-alcoholic fatty liver disease, which goes through a progression from hepatic steatosis or fatty liver up to NASH, non-alcoholic steatohepatitis, and then on to cirrhosis. Um, we talk about things like fertility. A lot of young women of childbearing age may not be able to menstruate and have fertility issues. And a lot of times after bariatric surgery, that comes back quickly. So that's something that we talk about. Sleep apnea is very common in this patient population. About 50% of patients, whether they know it or not, have obstructive sleep apnea. Getting woken up all night, waking up yourself or your sleeping partner waking you up because they can't sleep. That's not fun. Getting a sleep study is a good thing to do, which would diagnose you with obstructive sleep apnea, and you wear a CPAP. And then we talk about treatment options for that, and we get to bariatric surgery in a little bit. But moving on, reflux is common. We talk about that. A lot of patients are on anti-reflux medications, maybe have breakthrough symptoms, and cancers are more common in people that have obesity or morbid obesity. So we talk about things when I see patients. Are you getting your mammograms? Have you had a colonoscopy if you're over 50? And actually, the American Cancer Society recently lowered the age to 45 years old. So have you gotten a colonoscopy? You might be at increased risk for colon cancer if you're obese and morbidly obese. So it's something to consider. And the good news is when we treat obesity, a lot of times with weight loss, people's risk goes down. In the bariatric surgery literature or data, there's a lot of improvement back to normal with successful weight loss. So that's something to keep in mind also. And another thing is that with increase in weight, the number of those medical problems and the severity of those medical problems gets higher, goes higher. And so a lot of those medical problems, things like blood sugar or cholesterol, liver disease, all of those things start to be affected. And when we are talking about weight loss, even losing a little bit of weight can help significantly. At about 3%, your blood sugar starts getting better and triglycerides. When you get to about 5%, the liver starts, 5% of total body weight loss, your liver starts to improve. And when we get to 10% or even 15%, you start looking at reduction in cardiovascular events and mortality and remission of type 2 diabetes. So we want to get more weight loss, obviously, to have those medical problems improve or even go into remission. Um, so just to kind of briefly summarize, and then I'm going to go into each one of these and maybe use this as at the end as a conclusion. But we're going to talk about behavioral modification, which is really, the mainstay, and or lifestyle change. I mean, this is very important to eat healthy and exercise. We're going to talk about that, and you can get about 3 to 5% weight loss with eating healthy and exercising, and then adding on medications, you could get up to 5 to 12%, and then when somebody has a BMI over 40 or over 35 with medical problems, we start to talk about bariatric surgery, and you could get over 20% total body weight loss, which is very impactful. So I'm going to come back to that slide, and we're going to go through each of these. So lifestyle intervention, which is behavioral modification, is basically eating 3 small meals a day, cutting out snacks, exercising regularly. you could do additional things um, like apps on your phone to record your intake, whether you talk about MyFitnessPal or different apps that are available, and that tracking calories um, and doing that helps to assist with weight loss. When we talk about things like high intensity behavioral counseling, for example, at JCA, they have the wellness connection with a wellness coach. And when you do multiple visits, that helps you stick to a diet better. But in the end, despite doing everything to have lifestyle change, a lot of times in the long run, less than 5% of people who are morbidly obese can lose the weight and keep it off long term. So, and the other thing is about dieting, especially, is is that when you go on a diet, as opposed to lifestyle change, but diets in particular, when you do something and you make a sudden change, your body tries to drive you back to your original weight. You don't really change your set point when you do a diet. And what happens is you have different hormones that increase your hunger that are elevated when you lose weight. There's a good study from New England Journal of Medicine, which they took baseline blood tests before you started the diet, and then at uh, 10 weeks after you stopped the diet, and a year after you stopped the diet. And what they saw was that people's hunger, and this is even a year after your diet was done, your hunger is higher, and your hunger hormones are higher, and the hormones that make you feel satisfied after a meal, they are lower. So when we do a diet, and we don't change the set point, the biology of your body tries to drive you back to that original weight. And so that's really the main issue there. We know that people can be successful with dieting, but in the long term, we have a very hard time as physicians having patients be successful in the long term. So then medications comes along, and the goal of medications is to help patients stick to a healthy diet better. So they're having smaller quantities and achieve better weight loss. And going on medications is indicated medically, at least, when somebody's BMI is over 30 or if it's over 27 with a medical problem associated. And if patients, like I said, if they've been unsuccessful at losing and maintaining weight loss, then medications are start to be discussed. There's a lot of medications that are out there. Phentermine is the one that's been out the longest. Um, this has been out since the 1950s, and there's usually not a lot of side effects. Sometimes if somebody has uncontrolled hypertension or coronary artery disease, we would not put them on phentermine, but usually at a low dose, you take it in the morning, there's less side effects with a lower dose, and you have less hunger and can achieve decent weight loss with that. So the medications that are approved for long-term weight loss, phentermine is only 3 months, are orlistat, which prevents absorption of fat to some degree. On the downside, you have some oily stool or oily oil in the toilet, and sometimes some abdominal discomfort. But that's one. Sometimes you can control the discomfort if you add a fiber supplement, for example. Belviq was one that was put out in 2012 that was recently taken off the market by the FDA because of increased rate of cancers in February 2020. So that's one less. Qsymia, which is a combination of phentermine with topiramate, which is a anticonvulsant. That one is successful in some patients. Contrave is naltrexone, which is actually a narcotic or opioid receptor antagonist combined with bupropion, which which is for depression. And together, they have a synergistic effect and reduce appetite. And the last one is Saxenda or liraglutide, which is injected, and that's a treatment for diabetes, but also has some appetite suppression. So that's another one that's out there. And when you look at all of those, what we do is we subtract the amount of weight that you would lose on a placebo versus the amount of weight that you lose with the pill. So placebo is a fake pill. So when we subtract the amount of weight loss from the medication to placebo, you get the true benefit of the weight loss medication. Placebo subtracted weight loss. And so in kilograms, you're looking at about 2.6 kilograms with orlistat versus with Qsymia about 8.8 kilograms, so maybe 20, 25 pounds. And there's a whole bunch of studies, and essentially over time, people lose some weight, maybe about 10, 15 kilos, and then they tend to gain it back. So in the long term, if you come off the medications, that's the downside. There is, when you look at people who can achieve, let's say, 5% weight loss with 52 weeks at the top dose of orlistat, you do get about, I have one slide here, 73% weight loss with orlistat versus about 45% if they're in a diet with lifestyle intervention. When you do that lifestyle intervention, you stick with it, 45% of patients achieve 5% of total body weight loss, which is pretty good, versus 73% of orlistat. And most of the medications are pretty similar to get 5%. When you start looking at 10%, then orlistat, you got 41% versus 21% with placebo to get out to 10% weight loss. And let's see, Qsymia was 37% can get to 10% weight loss. In that study, 7% that were on a placebo. So there are some people that can do that. I think the important point is that there is a lot of individual variation. Some people will respond with medications, and other people are non-responders. And I think to kind of summarize that, there's really no magic bullet when it comes to medications. Most medications do have side effects. They're expensive. For example, orlistat was about $6,000 for 4 years, and in this one study, 7-pound weight loss over a placebo. So that's expensive for not a lot of return on the investment, and not substantial weight loss to really impact all of those medical problems that we talked about before. That's really the key. Patients may have a high rate of failure when they stop the medication, and again, feeling like a failure because you're not really addressing the biology of your body that kind of drives you back to that original set point. So we need to come up with something different, and that's where bariatric surgery comes in. Back in 1991, the National Institute of Health looked at bariatric surgery and all the studies that were out there, and basically they said that bariatric surgery was safe and it was the most effective treatment for morbid obesity, and it can improve or resolve a lot of those comorbidities or medical problems related to obesity. They felt that diets were more likely to fail, but patients should attempt lifestyle changes before they go on to surgery, for example. And candidates for surgery were BMI over 40 or over 35 with a medical problem like type 2 diabetes, hypertension. Very important that they mention patients need to fully understand what the operations do and what the patients need to do to have long-term success after bariatric surgery. I think that it's very important that patients need to know the lifestyle changes, because the lifestyle changes we talked about with medical weight loss or medications, you still have to do them with bariatric surgery, but you just have a better tool, and your body, you can adjust your set point. Okay, so let's see what else. I did want to mention that since 1991, there's a lot more studies that have come out. There's something like 29,000 bariatric articles or bariatric studies up to 2018, which is a lot. So we know that it's safer, we know that it's effective, and so there's a lot of evidence to support bariatric surgery when we talk about diabetes, coronary artery disease, or heart disease. So, so that's that. Okay. So I have another prop here to look at the different operations, and I'm going to go through each of these. So they all work because you eat less. Basically, when you do lap band or a sleeve with a small pouch or the small stomach pouch with the bypass, you're restricted in the amount that you can eat. There's hormonal changes with the sleeve, with the bypass. This is the biliopancreatic diversion with duodenal switch. Lap band, sleeve gastrectomy, gastric bypass, biliopancreatic diversion with duodenal switch. These three have hormone changes, and so really they work in a combination of ways. The lap band is not really done anymore. I'll just mention that it's essentially obsolete or not used. It's less than 1% of operations that are done in the United States today. It's removable, and ultimately about half, 50% of the ones that were put in were removed by 5 to 10 years. About half of people that still have them in place have success. So I would say about 25% overall. You know, some people had good outcomes with them, but overall the success rate wasn't high enough to offer, so the rate's gone a lot down. Sleeve gastrectomy is the #1 operation now in the United States as of 2013. Taking out this part of the stomach makes you removes one of the hunger hormones. So at about 3 years, 50% of people are less hungry than they were before they had the operation. And the size of the sleeve, we take off about 80% of the stomach. This part of the stomach is completely removed. So the one downside with the sleeve that I would mention is that if you have significant reflux to begin with, you might not want to do the sleeve. You might more consider the gastric bypass because about 20-30% of people that have a sleeve may have new onset or worsening reflux. Gastric bypass has been around 50, 60 years. We make a small pouch, divide the stomach, and then we divide the intestine and bring that small intestine to the stomach pouch. So food bypasses the stomach, all your digestive juices kind of join down there, and you absorb your nutrients further down in your intestine. So it's a great operation. It's more complex to do because we're dividing and reconnecting bowel, so there are more potential complications. That's not to say that they're at a high rate, but it is a little bit higher risk than the sleeve. The other thing is, by bypassing the first part of your small intestine, you could have some additional nutritional deficiencies. With the sleeve, we do 2 multivitamins a day, B12, and with the bypass, you have to take vitamin D with calcium in addition, and iron, so you don't get iron deficiency anemia or osteoporosis. Actually, with the recent 2019, one of the societies, the bariatric societies, they recommended that sleeve patients and bypass both take those. But for what it's worth, with the bypass, you had a little bit higher risk of those deficiencies. So anyway, the bypass, it's a little bit more surgery, a little more potential complications. We would recommend the bypass in patients that had severe reflux to start. If you're on a medication and you're still having breakthrough symptoms, you might strongly consider the bypass. Or if you have type 2 diabetes, you have more impact, remission. I don't use the word cure, but remission or um, improvement of your type 2 diabetes with the gastric bypass. And so some patients, if they want the most impact for their type 2 diabetes, they would consider the bypass. But you do have some significant improvement in the sleeve. About 70% of patients in the sleeve have improvement or remission, about 85% in the bypass. Biliary pancreatic diversion, duodenal switch, that was the last one I was talking to. This is combining a sleeve gastrectomy with a long intestinal bypass. So you only have about 250 centimeters left to absorb food, really about 150. There's another variation of this where instead of doing two connections, there's one, and with that one they do about 300 centimeters, so there's less nutritional issues. With the BPD-DS, there's the highest risk of surgical complications, protein and nutritional deficiencies, severe diarrhea. So it's very critical that patients that have this have very close follow-up. This is about 1% or less of the operations done in the United States. The new variant of that with one anastomosis was recently endorsed by the Bariatric Society that I'm a member of, but for now, that's not one that is super popular, but we'll see going forward. Let's see, what else can I tell you? So weight loss in general is most with BPD-DS, and then with the bypass, then with the sleeve. On average, patients lose, if you're about, we try to use the term percent excess weight loss. So if you're 200 pounds overweight, over your ideal body weight, you lose about 60 to 70% of your excess weight with a gastric bypass, or about 120 to 140 pounds, about 100 to 120 pounds after a sleeve. What else? There is potential for complications. Pretty low rate of complications. Sleeve is about 3 in 1,000 where there's a leak. Bypass is generally about twice the rate of major complications over a sleeve, but still a relatively low rate. A leak after bypass is probably about 8 in 1,000 or so. What else? Hospital stay overnight for a sleeve and a bypass. We get about 90% of our sleeve patients going home the next day. Probably about 80% of gastric bypass go home the next day. Take off about a week or two from work. Usually sleeve is about a week off and a week light duty. Bypass about 2 weeks off, I would say. So why do you want to have surgery or consider that? Well, if you haven't been successful with medical weight loss, lifestyle changes plus medications, then bariatric surgery is the most impactful as far as improvement of those medical problems. Type 2 diabetes, one of the first studies back in 2004, they quoted an 86% improvement or remission rate with type 2 diabetes, 80% for hypertension, improvement or remission, and 85% with sleep apnea. So that's pretty good. So bariatric surgery can be life-changing and even life-saving. So that's very important to remember. Cancers go down, heart problems go down, and one study that I quote is looking at the 5-year mortality rate for patients that have surgery versus patients that do not. For patients that do not have surgery, there was a 6% mortality rate versus less than 1% mortality rate for patients that do have surgery, that they follow both and see the patients that don't have surgery, they have those medical problems that still persist versus the patients that have surgery. So there's a little bit of a risk up front, but surgery is minimally invasive. I think I might have skipped over that part. It's laparoscopic, and we have enhanced recovery protocols now. So the risks are relatively low, especially when you look at the long term. Okay, so let's see. I'm going to keep going. I'm kind of monitoring this, and I think Gene I don't know if you want to text me. I could keep going if I should stop or ask questions. I'm going to keep going though, unless I get a text. So let's see. Diabetes, I could talk more about that. Basically, if somebody has type 2 diabetes and the blood sugar is inadequately controlled with lifestyle and optimal medical treatment, all the diabetes societies recommend bariatric surgery if you're morbidly obese category over 35, um, with a medical problem or over 40, and it should be considered for BMI 30 to 35, although 30 to 35 is not currently covered by insurance companies. Let's see, I'm going to talk a little bit more about the Baptist Center for Bariatrics. We have this great interdisciplinary team where we work with your primary care. We work with Baptist primary care before surgery. A lot of patients need to have physician-supervised weight loss programs and satisfy 3 or 6 month programs for insurance. So we have you go to your primary care for that. And then after surgery, when patients lose weight, a lot of times they could come off of blood pressure medications or diabetes medications. And so we ask you to follow up with your primary care. We have a bariatric coordinator, actually several bariatric coordinators, Regina, um, um, and everybody in that office helps patients to get through the process to get bariatric surgery. We have 2 full-time dietitians. We have several psychologists that help with our program. We have a special hospital unit where every one of our patients have gone after surgery, so the nurses are great. They know exactly what to expect when patients recover after surgery. I didn't mention yet that um, I didn't mention that we are an accredited program for metabolic and bariatric surgery accreditation and quality improvement program, which is a joint quality program for the American College of Surgery and American Society of Metabolic and Bariatric Surgeons. Basically, we have the physical resources, human resources, standards of practice, and outcomes review so that we have great outcomes. Um, what else? We're community based, so we do not have a program fee. A lot of other programs in town have charged several $100s to verify insurance and request authorization. We don't do that. There's a seminar online. This is pretty good if you've watched this. This is a lot of the information that we want you to hear, but also online at baptistbariatrics.com is the webinar. And also you could, if you've watched this, then you could just call and we could check your insurance and bring you in for a visit to talk about bariatric surgery if you're interested. If patients do not have insurance coverage, we have low interest financing objects that we could set people up with. What else? As far as optimizing outcomes, I mean, we have a great program. We're always making it better. I could go through all that, but I don't know. I think now I'm gonna see if anybody has questions. Does anybody have questions that they want to ask me? Um, I'm gonna see if I can figure out how to find questions and ask questions. Ask away if anybody's watching. How you doing? Okay. All right, I'm just gonna keep going until I see that there's no questions. So before surgery, we have patients see a dietitian, we have nutrition classes, we have patients see a physical therapist if they, need assistance with getting back into an exercise routine after surgery. It's very critical that patients, and I didn't really get into all this because this is a little bit further in the talk, but I'm going to just go into all this now. As far as what you need to do well, you got to eat small portions of healthy food slowly after bariatric surgery, regardless of which operation you have. You do a high protein, low carb, low fat diet, fish, baked chicken, turkey, lean ground beef, and vegetables, a little bit of fruit. Don't need a whole lot of fruit. You're taking multivitamins, and fruit has a little bit more fructose. So low carbohydrate diet. You want to do not a lot of carbs, a little bit of whole grain, but not breads, pasta, potatoes. Essentially, those are vehicles for butter and cheese. So Even though that tastes good, it doesn't have a lot of nutritional value. Um, Healthy fat, but not fried greasy. An egg or two, avocado, that kind of stuff. No junk food, cake, cookies, cake, chips, candy, that kind of stuff you don't want to do. After surgery, we have patients not drink while they eat because you just wash the food down and you can eat more. So that's a way to eat. That's a way to beat the operation. And then when you drink, you have to have 0 calorie liquids only, water, unsweet tea, water with lemon, no artificial sweeteners. And I think that's important because your tastes change if you let it change. But if you have the sweeteners, you're gonna probably still crave the sweeteners, and all those calories add up. So 0 calorie liquids only. Very important to exercise every day. Um, Walking for about an hour a day. Um, A lot of cardio if you want to cross train with elliptical or exercise bike. Invest in a treadmill or something, put it in front of your TV, or go to the gym when it opens. Outside is great, but not in the summer, I guess. What else? So getting cardio, and it's important also to do muscle work. So everyday cardio, twice a week muscle, because you want to lose fat and maintain muscle mass. If you lose if you lose muscle mass, that's not healthy. So doing things like exercise classes or light weights, high reps on the machines, or working with a trainer, doing an exercise video. And then very important, when patients have surgery, they follow up with our program to see our team. We check your labs, make sure you're doing well, not have any issues. And we have you see a dietitian every time you come back to my office. Um, and what else? Let's see. Oh, I didn't mention um, like calorie counting maybe twice a week. You don't have to do that every day. It gets a little cumbersome, but calorie counting makes you an expert in planning your meals. And when you come back to see us, we could help you to optimize your weight loss when we have something to work with. So that helps. Let me see if there's anything that I missed that I really want to mention. What else? We have a pre-op class that really goes into everything that you need to do when when you come to the hospital for surgery, or even before surgery. Doing well after surgery starts before surgery. We get people to start eating the diet that I mentioned before surgery, so maybe start to lose a little bit of weight, start walking every day, prehab, or just getting more in shape, quit smoking if you're smoking, obviously. In the hospital, we have this enhanced recovery after surgery program that optimizes outcome. So you receive multiple pain medications, nausea medications to prophylax or preempt those symptoms. So patients need less narcotics. When you have less narcotics, you have less side effects like nausea, vomiting, bowels backing up, and stuff like that. So outcomes are improved. We have a very low readmission rate. Um, our rate was 2% versus the MBSA QIP was 4%. I rounded up. It was actually 1.6% for us for that year, so that was pretty good. We have a great program, I mentioned. After surgery, you're doing you're doing full liquids for 2 weeks and soft food for 2 weeks. We talked to you about what all that is. And then very important to stay focused long term on eating the diet that I mentioned: high protein, low carb, low fat, exercising. We have support groups that are free and open to the public, led by a dietitian. We have guest speakers, a bariatric chef or psychologist. We have focus groups, like, for example, if you're early after surgery, if you're over a year after surgery. I think it's very important that patients before surgery go to the support group so they can hear what patients have to say. What else? We have an online Facebook community. I'm trying to get all this information in here, um, which is pretty cool. I wouldn't say I'm a big Facebook fan myself, but this is a whole online community for patients to communicate with each other. A lot of people have had the same questions after surgery, so we have our dietitians have maybe 30, or I don't know, so 30 videos, like 3 or 5 minute videos that you can look on to look at commonly asked questions. That's pretty cool. What else? Okay. All right. So I think I covered everything. I'm going the wrong direction. My slides. So I am going to just kind of summarize my talk with that slide that kind of talked about. I think I lost it, so I'm just actually, here it is. Okay, so as far as lifestyle modification, that's the first thing. You're going to do that after bariatric surgery. Lifestyle modification, eating small portions of the food slowly, exercising regularly. And you could probably get 3 to 5% total body weight loss. And so that's a good start. Diets are very challenging in the long term to keep that weight off. So it really has to be a lifestyle change. I don't like to use the word diet because if you do that, you're going to gain the weight back. You want to try to slowly change your set point. Medications help with having success with lifestyle changes. In the long term, coming off those medications, a lot of times people will gain weight back, but that is a good second option. Bariatric surgery, when patients have over BMI 40 or over BMI 35 with medical problems, bariatric surgery is the most successful long-term treatment and intervention for morbid obesity. And I hope you contact our program. The phone number is 202-SLIM. Our website is baptistbariatrics.com, 202-SLIM, SLIM, or baptistbariatrics.com to hear more about our program. Okay. My wife is texting me to ask, what does long-term success look like? Successful weight loss, for one, is you've lost weight, which what that does is that impacts those medical problems like type 2 diabetes, and we talked about obstructive sleep apnea improving, and all those medical problems tend to, that's the bottom line is, these medical problems, diabetes, hypertension, heart disease, cancer, everything. There are study after study on each of these, how they improve or go into remission with bariatric surgery. And I think when you add all that up, you have, bottom line is successful weight loss, is improved mortality. I mentioned 6% versus less than 1%. And that was back when they were doing open surgery, which had a higher risk and a higher mortality rate. So I'm sure those numbers have gotten better. Let me see if I should stop or just sign out. Okay, I don't know how to check for questions. I don't know if you're going to edit this and cut me off here. I don't see any questions. Hopefully somebody's watching this. Let's see. Okay. Should I stop? I'm signing off. Okay. Trying to just look on the side now. I figured this out, but I don't see any questions. Karen asked the same question, and then Rachel texted that. Okay, I'm signing off. Everybody have a great day.